Okay. Okay, so I guess we're recording. All right, everyone, it is November 12th. It's about 1:45 in the afternoon. I just want to start part two of the axial skeleton. So remember, this is going to be the midline. So the central nervous system, we did the cranium last time, and now we'll do the central nervous system with the spinal cord, which is going through the vertebral column. And we'll start with that, and then we'll get into the os coccyx, pelvis. Well, we'll get into the sacrum, and then the os coccyx will be part of it. Technically, the appendicular skeleton, there's been a book or two who said it's part of the axial, but for right now, we'll just call it appendicular, right? Let me just fix this here. Okay, slideshow. Current, there we go. All right, so we'll do the vertebral column. I got some props today. I should have gone home and got other ones, but I didn't think about it. All right, so we'll do the vertebral column. Remember, your central nervous system, your spinal cord is going to be going through that. It's there for protection, and we'll be going through the different vertebral bodies in different shape, and realize that each section, whether it's cervical, thoracic, or lumbar, is going to be for a very specific type of motion, a range of motion, and they're really designed to only do certain range of motion depending on the angle of the facet joints. So I'm sure you all realize with your neck, you can rotate it on the axis. Thoracic, you can do a little bit of twisting. Your lumbar is really there more for flexion and extension, but we'll go over that. And then I'll try to remember to talk to you about facet tropism and a couple of things like that. So it extends from your skull to your pelvis. So from your head to your waist, let's just call it that generically. It's called the spine or spinal column. It's really functioned to transmit the weight. And I mentioned last class, the weight of your head is sort of like the weight of a bowling ball. We want that curvature correct of the cervical spine, so you don't have what's known as forward head carriage. So your head isn't leaning forward. If it's a lot of strain on the talked about the ligamentum nuchae and that how it attaches to the base of your spine. And you know, you all probably realize, or some of you realize, you have all that tension. So it's either the right or left side of your neck, or if you don't carry it there, a lot of people carry that tension in their lower spine, depending on postural, how you're sleeping, and things like that. All right, so you know, back in the day before modernization, we probably were doing a lot more things outside. We weren't really walking on these flat concrete surfaces. We weren't driving, sitting in our computers. You're probably a lot more active. But that's really something more for a seated lecture discussion. But for right now, we'll talk about these. So this functions to transmit weight of the trunk to lower limbs, surround and protect the spinal cord. Major functions, right? Because once it's damaged or the integrity is breached, we can get some kind of a septic infection, meningitis, and things like that. Provides attachment points for the ribs and muscles, and we'll see coming up the head of the rib will attach posterior, then it'll wrap around, and it's going to hit some costal cartilage. And remember, I told you guys, costal usually always means rib. So anything that has costal in front of it, it's going to be oriented to some type of a rib location. Flexible curve structure contains 26 irregular bones called vertebrae in 5 major regions. We're talking about cervical, thoracic, lumbar, sacral, and so on. Okay, so there's well, coccyx, yeah, I guess, okay. So the cervical consists of 7 vertebrae, thoracic 12 vertebrae, lumbar is 5, and the sacrum really is 1 bone, but prior to birth, it was 5 or 6 bones, and they fused together. And the coccyx is the tail bone, I guess you want to call it, also fused bone that forms a terminus end of the column. And sometimes if you fall in the ice or whatever, you can flip that little piece. I brought this guy in. You can flip this little piece here. You can flip that, all right? It can be very painful, all right? there's a procedure where you can fix that, but it involves digital palpitation of an area, and you can hit that button. All right. So just remember, it says right here, remember meal times for the cervical, thoracic, and lumbar. 7, 12, and 5, or if any of you have emailed me privately, my email address is C7T12L5S1. All right, so that's the reason for that. All right. So curvatures, there's 4 main curves in the column to help increase resiliency and flexibility of the spine. So we're going to go over how the neck should have 1 curve, and we have kyphosis and lordosis, and how these things line up. So if it's done correctly, your ear should literally line up over your pelvis, but contingent upon, can be something contingent even as simple as birth. It can get things out of alignment or whatever, or posture. And then we're going to see a lot of these changes. I think I'm predicting that in the next 10 or 15 years, major change in the populace as far as their spine, just due to all the things we do digitally in front of us. Right? So that can have a major impact. All right. So cervical and lumbar, the superior and inferior, should be concave posteriorly. So we'll see a picture of that. I don't know. Maybe I can do it on this guy. Maybe. All right, so it's concave posteriorly. This is going to be convex. Then it goes concave again, and then convex sort of. All right. So just realize they're going to be opposite. All right, and these really start developing during the cross-collar pattern when you're crawling, but that's beyond the scope of the course, really. So here's your vertebral column, and there is your 7, C7, all right? And we can talk about the height of that. Some people have long necks, short necks, and actually, truth be told, even a giraffe, same amount of vertebrae. They're just, the vertebral bodies are huge, obviously. All right, and then we'll go over some of the features of all these vertebrae that are common, and then there's some differences in them, and they're all there difference are depending on the amount of weight that these vertebral bodies have to hold. And just realize, sort of like the base of a building or a pyramid, or however you want to think, realize most of the weight's going to be on the bottom. So lumbar vertebral bodies they're kidney shaped, and they're very large to take that weight. And we'll talk about the intervertebral disc, the nucleus pulposus, the annulus, and how they're there for shock absorption and to resist these great big shearing forces. And we'll talk about that coming up also. I don't forget anything. And if I make a mistake, if you want, go into my YouTube channel and just make a comment, and I'll go in and fix it. All right, so ligaments, along with trunk muscles, help support the vertebral column. All right, so I see a lot of patients with a lot of low back pain. Usually these trunk muscles get really, I want to say exhausted, very tired, or sometimes they get so hypertonic, so completely contracted that they literally forget how to relax. And that's where, a lot of these yoga, tai chi, and some of these other relaxation exercises, people may think they're ridiculous or stupid or too spiritual, whatever, but they really are designed to help you relax and actually go back to that homeostatic state. It's much healthier for you mentally and physically. All right, so your physiology runs much better if you're in a homeostatic state. Right, so we have anterior and posterior longitudinal. So just kind of look, we're going to have anterior, you can see this, anterior and posterior attaching to all these spinous processes. These are going to be ligaments, and they're going to be there so that you can't it's going to stop some of this twisting of it, and so you can't overflex or overextend. Right? These are continuous bands from the neck to the sacrum that run down the front and back of the spine. And once again, their job is to support and prevent hyperextension, going all the way backwards, or hyperflexion all the way forward. Right? That being said, I think I mentioned before, if I got a patient and they're on the table and they're face down and I'm just kind of figuring out what's going on, I can honestly tell you within 3 minutes of palpating their spine or checking things out, I can tell that whether they were a gymnast, ballerina, dancer, something, even some cheerleaders. I can tell the damage or the alteration of the curvature and rotation of the spine just by signing. I don't even have to. I'll just ask them, you know, what's going on here? Were you a dancer? Were you a gymnast? Were you whatever? Because you're literally in some of these things, you are hyperextending, so you really stretch out these ligaments, and you can start jamming these facets together, and compressing vertebral bodies and all kinds of things which are not good. I mean, they're good in myopically initially because you can do some things that you really some people can't do, but in the long run, especially with ballet and things, I've seen people's feet that are just totally just destroyed. Arches are completely destroyed. Anyway, beyond the scope of the course, sorry. The ligamentum flavum connects the adjacent vertebra, and we'll see that. Vertebrae, vertebra, whatever you want to pronounce that. So these are going to be very short segments, and they connect each vertebrae to the one above and below it. So we have the ligamentum flavum are very, very tiny, connecting each vertebrae. I can just do it. Probably could have gotten that example, but anyway, these are not really correct. But just connecting each vertebrae together, and then you're going to have that long ligamentum flavum going all the way up and down the spine. So we have sort of a bit of a reinforcement there. Here's a sagittal cut, and here's your intervertebral disc. So remember, between each vertebrae, except for C1 and C2, there's always going to be a disc there for compression. And there also is there, like with the meniscus in the knee, just the compression to stop the shearing forces and stop extreme rotation. So here you can see there's the anterior longitudinal ligament. And radiographically, this kind of, depending on the radiograph, it literally looks like candle wax that was stripped all the way down the front. All right, we have the same thing sort of in the back. All the spinous processes are connected by the posterior longitudinal ligament, and then here are those ligamentum flavum. They're literally just attaching each vertebrae to each other. And here's that posterior longitudinal ligament and the anterior. But look at how wide that is, going all the way down. It's really sort of all connected in one long strip. All right, so this, remember here too, if you think about this, the anterior longitudinal ligament is designed so you can't flex all the way backward. Posterior is the one to stop the anterior flexion. But if you've seen, you know, unless somebody has Marfan syndrome or something like that, if you've seen gymnasts or other people, they can train over time to do that, to stretch them out. But you also remember with these gymnasts, they have extremely strong intrinsic core muscles. All right, so they could train the ligaments to stretch a little bit, but please realize that they have actually all these core muscles that are completely strong, giving them support so they're not damaging their spine if they're trained properly. Our intervertebral discs are cushion-like pads that sandwich between the vertebrae and they act as shock absorbers. I did have, good grief, okay. Yeah, so if you look kind of in here, I don't know if it's going to show up on the MacBook here. But you have these discs, these are going to be the shock absorbers. So they compress, and once you compress it, you really can't overly rotate, all right? The other thing I want to point out here, and we'll talk about later, that's a bulging disc, all right? So if somebody was lifting and twisted, or there was weakened or whatever, and that nucleus pulposus comes out, sort of like the jelly in a donut, that is literally compressing on that nerve root. And if you know anyone with low back pain, or they say I have sciatica, which is inflammation of the sciatic nerve, extremely, extremely painful. So patients will tell me, I don't know what's more painful, my dental issue where I need root canal or my low back pain. They're equally as excruciating. All right, so the nucleus pulposus is the inner gelatinous nucleus. So you can think of that as kind of like jelly in a donut, I guess, is the easiest description. Gives a disc its elasticity and compressibility, all right? So you have that gelatinous, so just think of very, very like gummies or like Jello shots that are thicker. You have that compression force, right? You have the annulus going all the way around it, like a steel belted radial ply on a tire. But if you compress that and twist, and it'll find the weakest spot, and that gelatinous material can just extrude out of there, and that will compress the nerve root, causing massive pain. Okay, and then the annulus fibrosis, the outer collar composed of collagen and fibrocartilage. We talked about that when we were talking about tissues. So the collagen is there for strength, available flexibility, but the fibrocartilage is there with fibrotic tissue to give it a lot of strength. All right, limits expansion of the nucleus pulposus when compressed. This is kind of a stopgap safety mechanism there. So here is a view of a vertebrae. Looks like it's anterior to posterior. So, or I mean superior to inferior. Here's your anterior, posterior. So whenever you're orientating yourself, you've all seen a baby or young kids, you know, when they're toddlers or 5 or 6 or whatever, you can literally see all those spinous processes in their spine. You can see them in some adults too, but sometimes these lateral components are hidden by quadratus lumborum or these iliocostalis muscles or whatever it happens to be, or adipose tissue. But in young children, you can usually see these. So there's your vertebral spinous process. It's a posterior aspect, very, very posterior aspect. Something here on this little mini skeleton. You can zoom in on that if you want. Or I found this model. It's probably as old as I am. But you can see here these, and you can feel these in the back of your neck or whatever. Well, on most people, you can feel that in the back of their neck. But just realize the point I want to make here is your spinal cord is going through the center. Right? So if I were to do superior to inferior, that's what it would look like. Right? So just these are kind of color coded for you here. Yellow and green says general, somatic, afferent. Right? Afferent's always going from the body up to the brain for interpretation, goes to the homunculus, and it goes anterior, and then homunculus there decides how to respond. It sends an efferent message, right here through the anterior portion for motor function, or to give you a correct response to the impulse. Okay. So here is a MRI. Looks like, yeah, it is MRI. This is a sagittal cut, and you can see. And when we get these images, we can actually go in. It's called a scout film. We can go in and we can see. They'll tell you whether they were taking this view, whether it was the right side was closest to the bucky or the film on the left side. So we can tell whether it's going from right to left or left to right, and you can actually get slices of this. And if you look here, we can see that's herniated. So this literally right here, see how flat that is? That should be the same all over here. We really don't want an indentation here or anywhere because that's going to show us that there's extrusion of the of the nuclear pulposus from the disc and compressing into that. Now realize this is that posterior longitudinal ligament. It's actually compressed into there, and then if it pushes a lot, it's going to start impeding or pushing on the spinal cord. If it gets really, really bad, it's pushing on those nerve roots, causing major, major pain. And if it gets bad enough, people, they won't be able to get the impulse. They'll start losing motor function because even though the brain cell would move their leg, the nerve, these dorsal nerve root and things, these get so compressed that they can't, the image can't propagate. They can't move their limb or muscle or whatever over a long period of time, and it can become quite debilitating. All right, so severe physical trauma of the spine may result in one or more herniated or prolapsed discs. All right, and these are going to look like that. Okay, so if someone's in a car accident or you know, let's say they jump somewhere and they stop and the compression forces compress, or a lot of times going into healthcare, you have like double or single assist, or you're helping a patient and they lose their balance and you kind of stop to help them. You know, you're not really prepared for it that second, but you go to grab them, you get all that weight and a twisting motion, it can be just enough to herniate a disc. Usually involves rupture of the annulus fibrosis. Remember, that's that fibrous tissue all around that disc, resulting in protrusion of the nuclear pulposus, which compress on the spinal cord and nerves, causing numbness and excruciating pain. Like I have had patients who literally almost crawled into, they're hunched over, and then you go to, you know, do a couple things and they can literally walk out. They still might be in a little pain, but functions definitely increase. So treatment, exercise, massage, heat, painkillers, surgical intervention. If non-surgical treatments are not successful, you know, we always try to do non-surgical. So it can be flexion distraction or some of these other things. I won't get into the whole philosophy of that. All right, abnormal spinal curvatures can be congenital, means you're born with it, or result from disease, poor posture, or unequal pulling of muscles in the spine, or, you know, kyphosis can be acquired or can be born with a congenital disease. You could have tuberculosis of the spine. You could have osteomyelitis, inflammation of the bone. It can just start deteriorating those vertebral bodies, and they'll start getting crushed. You know, I try to educate teenagers or young adults when they're going into these weightlifting regimens not to overlift or deadlift, because you literally can start crushing those, usually it's the thoracic vertebrae, just because of the kyphosis. And, you know, I go to LA Fitness all the time, and I just see all this craziness, and I learn to keep my mouth shut about the stuff I see. All right, scoliosis. You probably all heard this word. Abnormal lateral. All right, so scoliosis is going to be when this, so we can have a single, double, major, depending on the curvature. What will always happen is that spine will have a deformity or whatever. It could curve one way, left or right. And what will happen, the muscles on the other side of the spine, contralateral, will contract. And the reason is, I said last time, we had something called the righting reflex, where we want those eyes always on the horizon. So if you had a curved spine, you don't want to walk around with your head tilted. So your body will compensate to make sure your navigation system is always on the horizon. Kyphosis or hunchback is abnormal dorsal, the dorsal or posterior, we learned those terms in the beginning of the semester. Common in people with osteoporosis, tuberculosis, rickets. The rickets is a disease when there's not enough vitamin D because we can't produce it because of lack of sunlight in the northern environment, or lack of vitamin D for some reason. So vitamin D helps regulate calcium into bones. We talked about osteoblasts and osteoclasts. All right, so with rickets, what happens is their cartilaginous portion of the bone never ossifies through calcification. So their bones, or long bones, are very, very pliable. They don't calcify. So these people have bowed out legs. Rickets, osteomalacia. In hunchback, you can see this in the older population. Sometimes they'll be male or female. They'll be hunched over a shopping cart, and you see that downward hump, or that great big hump between the shoulder blades. That's an extreme example of a kyphosis. All right, and I see some patients who have too much kyphosis, and a lot of gymnasts and dancers, they have no kyphosis, right? Because they're always bending backwards, doing a lot of these moves, and they literally start taking that curvature out of their back, and then it messes up all of their posture later on. Lordosis or sway back. So the low back is very, very curved. Right? So this curve in here, we would say it's going to be concave posterior. It's literally emphasized. It's really, really curved like that. Now you see this in pregnant females, which is normal for a short period of time. You can see it in males with metabolic syndrome, or they may have a huge, call it beer gut or whatever it is. It just forces that curvature in the lumbar to be accentuated. Remember, that's going to take that pelvis. It's going to start bringing it, rotating it into flexion. It can start weakening the glutes and all the posterior muscles beyond the scope of the course, but biokinetically, it can cause a lot of damage. And we'll see a picture of that coming up, I think. Yeah. So there's scoliosis. This is a single major. I have a few patients with double major. So it curved here, then it recurves here, and then it curves again here. And what we said, we want to get that spine, we actually want to get the head level. So the body will do whatever compensatory measure needs to be to indicate that, those eyes on the horizon, that navigation system. All right, here's kyphosis. You can look. All right, extremely. All right. And this can happen too. I've seen it sometimes with extremely tall populations. So, I'm 5'0". So somebody who's 6'3", 6'4", 6'5", for them to adapt in society, they are usually bending down because they're looking over the top of everyone. So that can induce this too. I wouldn't say they're born with it, but it can be induced through postural posturing. And then here's the lordosis. This woman is pregnant, and the weight of that fetus is anterior. It's pulling this down, and she's going to have an increased lordosis, but generally that should go away after delivery. So the structure of the vertebrae. So we'll talk about some things that are very, very common, and then I'll go over some portions which make each portion very definitive. So the moment I can't give you guys a lab practical or whatever and show you these things and point out the differences like I would be able to do in person, but I'm hoping that the mastering exercises will do that. But I'm going to point them out here for you anyway. So the body, any portion is always going to be anterior is the body. And you can see the difference in the sizes here. Right. See the difference in the size there. So this would definitely, this is a lumbar, just due to the size and the weight distribution. All right, this I can tell by looking at it from the side view. And this heart-shaped vertebral body, this is thoracic, and I can also tell by the angle of the spinous process there. And this one happens to be a cervical. It's very, very tiny. The thing that also gives away is there are foramen in here, vertebral foramen. That's for a very, very specific blood vessel to come up and through and feed part of your cranium there. So the body, your centrum, is the anterior weight-bearing portion. There's a the body here, distributing the weight. Then we have some pedicles on the side. You can look in your book for these two, right? And the lamina. These are these lateral portions here. Here. So orientation. Anterior, posterior. Here's the lamina, right? It's on the lateral side of the spinal cord. Have you ever heard of a laminectomy? All right, if this is compressed somehow, if this disc starts being compressed, we can go in and we can cut that and relieve some of the pressure. Right. Vertebral foramen, series of vertebral foramen. See that in there? I can look through that if I wanted to. All right. Intervertebral foramen, lateral openings between the vertebrae, and passage for the spinal nerves. This would be the vertebral canal, right, and through here. And just remember, with this, this is actually C1, so the foramen magnum is going to be on the skull, and then the spinal cord is going to come through there. So you can look in your book. Always remember, posterior is in the spinous process. Anterior is the vertebral body. Vertebral foramens, where the spinal cord is going to be in. Lamina is here. So just realize if your disc was here and it was compressed, it was pushed out here. If we went in and we just cut these lamina here, we get rid of some of that pressure. You give it a little bit of breathing room per se. All right, so vertebra have 7 processes. Spinous process always projects posterior. Transverse process are always going to project laterally, remember lateral. All right. Superior articular process is here, superior. And then inferior articular processes protrudes inferior. And these, I didn't grab exact ones. But could have got a better example, but you'll get the gist of this. Right? But they're designed to line up. So the superior on this lower one is going to line up with the inferior ones here. All right. And there's called the facet. So these line up specifically for whatever motion that happens to be. All right, and these, I don't know if they'll play. Oh, they are. Good grief. Finally. So these should be embedded. You can get a view of these. Look at that right there. So if I was doing a lateral an oblique X-ray, right, I could go in and see what's not lining up with that patient. All right, cervical vertebrae. So we'll start from the top. Cervical. Remember, there's 7 of them. The vertebral body is going to be smaller because it's the top. It's going to be the least weight bearing of everything below it. So just remember though that the cervical spine has to hold that bowling ball weight cranium with the brain net. So it's holding a severe amount of weight. All right, C1, C7, smallest, lightest vertebrae. C3, C7, they all have something very similar. Now C1 and C2 are very specific vertebrae, and I'll show those to you. That's the axis and atlas. And we'll talk about this. So C1, remember, has their condyle on there to support the skull. We saw last lecture that external occipital protuberance and those condyles, how they sit there. And we're actually sitting on, I got this orientated right now, be embarrassed. Yeah. So you can see that. I'll try to at least forget the cameras here. There's a little scoop out here where the condyle of the skull is going to sit in there and rotate. It's going to allow you to nod, all right? So C3 through 7 should be bifid process, but maybe there's cervical. All right, so this is C1, 2, 3, 4, 5, 6, and C7. And C7 here, if you look, sticks out. So this is the prominence. You'll see that. You can feel it on most everyone's neck. And just, you know, guys, if you're going to palpate someone's neck or palpate any part of the body, you need to get that permission from that person. Otherwise, it's called assault. Right. So these all have oval-shaped bodies. The exception is C7 spinous processes are bifid, and that's the protuberant one. And bifid always means two. All right. Like a snake has a bifid tongue, all right? And these will have, a good example. Let's see that, I'll try to line it up. But it's bifid, right? We have a large transverse vertebral foramen. Right? And C7 is the vertebral prominence. It's the one that sticks out the furthest. And that, for me, that's usually a landmark. I know exactly where the cervical ends and the thoracic starts. Huge landmark. So if you're done looking at this, you can go through and look at the cervical, thoracic, and lumbar. So what are the differences? So on your exam, I will give you one or two of these, depending on how the random generator comes up. And we'll give you a picture of that, and you should be able to tell by the landmarks or the specific markings or the side of the vertebral body or the orientation of the transverse process or the spinous process. Is that cervical, thoracic, or vertebrae? Or if we give you the exceptions, C1 or C2, you should be able to notice the difference with those. All right. This is C1 here, the top vertebrae, very, very specific. There's the anterior, posterior, right? And C2 is going to fit right in there with C1. And C2 is going to allow you to rotate, all right? And C1 is going to allow you to say yes or no. And we're going to talk about the DENS, the auditory process. Those will be coming up. Right. And if you guys were able to look, you could see how these literally articulate or they glide. They're designed to fit on each other. Remember, these sets are also going to have that cartilage. We said that every joint is going to have cartilage and a little bit of fluid. So here are the pictures. You can tell by the body. Cervical, this is heart-shaped, more or less. This is more kidney-shaped. All right. And if you look, the orientation of this is more oblique. This is actually literally more at the 180. This is more at like the 60 or whatever you know, however you want to orientate your thought process on that. And you realize that these facet joints and these transverse processes are lined up depending on the motion of that part of the spine. All right, so your cervical is really designed for more rotation. So our head we can do a lot more things with. Right? And then think about, well, what can we do with from our neck to our belly button? Well, what does that part do? It's really a lot more lateral flexion, okay? And then our lumbar. What can we do with that belly button to our pelvis? This hypoxia is killing me. All right, and here's like a lateral view. All right, so cervical, you look at the lateral view, spinous process and the angle. All right, now thoracic, you know, people say, oh, Dr. Phil, I remember what that is, but it's the giraffe one. So it looks like a giraffe from the lateral aspect. But just kind of look at the orientation of that spinous process. This one is down a little bit. This one's severely angled down. Right? Severely angled down. As opposed to, probably got another example. Well, there's C2. Really more completely out. Right? Now the lumbar, right, if you look at the lumbar, you can see this here. All right, but I want you to kind of look at how thick that is. It's very, very short and very, very thick. All right. And then the facets are there designed for just certain specific motion there. All right, so there is your cervical spine. Here, anterior, posterior, and then I want you guys to just kind of get in your mind there's an artery going right up through here. Right. So C1, the atlas, very, very specific. This is the top of the spine. Right. And then I said, C2 literally, C1 sits on top of C2. Right. The axis, there's no body or spinous process on this one. It contains anterior and posterior arches. Right. Two lateral masses here. Superior surface of lateral masses articulate with the occipital condyle. This is where that part of the brain sits on here. And they called it atlas because atlas from Greek mythology was holding up the world, right? So the atlas holds up your whole head. Movement is for yes motion, when you're nodding yes. With C2 has this dens, it literally fits right in here. You can see that coming in through here. There usually is a ligament that holds on, it clamps it in there. Look to the posterior arch, posterior tubercle. Remember, tubercle is always going to be a bump, and it's going to be muscles attaching back. You wouldn't have these rough tubercle marks if there wasn't some Sharpie's fibers. Sharpie's fibers weren't going to attach some kind of muscle in the periosteum. There's the axis. All right. Atlas is C1 axis. So you guys have probably heard of axis when you take trigger geometry or maybe algebra. When I showed you the knob-like dens, it's also known as the odontoid process because it reminded them of a tooth. Right? Dens is missing the body of the atlas. The dens is would be the actual body of C2, but it doesn't really have a body. They're just saying the dens would have been this vertebral body here. The dens is the pivot for rotation of the axis. This is going to cause you to be able to disagree or say no. So showing you, there's your odontoid process. Remember, C1 is going to be sitting on here. Superior articular facet of this, which is C2, is going to line up, all right, with the inferior facet of this one. So they're going to literally line up. And if you look, if I do this semi-properly, you're going to see that the angle orientation lines up just right with that. So there's a whole cervical vertebrae, C1, C2, C3, C4, C5, C6, C7. Once again, that's the vertebral prominence. It sticks all the way out. And that is an anatomical landmark. Thoracic vertebrae, there's T1 through 12. All right, they increase in size and articulate with the ribs. So when they say they articulate with the ribs touch them. All right, I'm going to show you quickly. There's your thoracic area here, and your ribs, the head of the rib. It's coming around posteriorly, attaching there. The head, the neck. And we have these grooves for intercostal grooves for nerves and blood supply. And then realize that the ribs are going to articulate anterior to cartilage, which is going to attach to the sternum. Right, maneuvering body, xiphoid process. And just realize your ab muscles are attached here, all the way down here. So that's where your ab muscles are attached there. I don't know if that's made up or not. But. So the body is heart-shaped and two small demi facets that articulate with the ribs. T10 and 12 have only one single facet, not two. All right, so they don't attach quite as directly as the ones above it. The vertebral foramen, if you look, I'm saying it's very, very round. Okay? They have a long, sharp process that points inferiorly. Right? Transverse process, all right, have transverse costal facets. And remember, I told you guys, whenever you hear the word costal, I want you to always think of rib. All right. Location of the articular facets allows rotation of the spine in this area. And give me one moment. So, see that? I'm actually hooking the rib to the area there. Right. All right, there's your transverse process. Same as kind of this area. So lumbar vertebrae, these are going to be the ones that are bearing all that weight. So it's going to be, that's got to be like L5. I think it's massive. So L1 through L5 is your lumbar. The bodies are massive because remember, they're holding all of that weight. That's superior, inferior. All right, and this is the part that usually gets misaligned or something going on. When we're talking about somebody with low back pain or sciatica, these come out of a place, and you don't know, chiropractor or PT or osteopath, you don't want them. We can just reline all those up and get everything lined up and hopefully get rid of that pain for you. So these have short, thick pedicles and lamina right in here. They have flat hatchet-shaped spinous processes, point posterior. It's like a hatchet. All right. The vertebral foramen is triangular, and you can definitely see that here. Triangular. So remember, the thoracic was very, very round. This is going to be looking superior and very round. This one is very, very triangular. These facets, all right, locks the lumbar vertebrae together to prevent rotation. So your lumbar, if you look kind of at the angle here, see that angle here. These, they come together right here at this angle. So these literally are not really designed to rotate. These are really more for, with that angle, they're really, really designed to cause just flexion or extension. All right. Or I'm going to point out here, you can also have somebody, these angles down here, sometimes when they, during embryology or before birth, this is all cartilaginous. If somebody has spina bifida, sometimes these posterior arches don't ossify, they say cartilaginous. But sometimes the angle of these are not the same. They have facet tropism. So one might be the right orientation, one might be more angled out. All right, so you might see someone whose spine is slightly rotated at the base, and that can really mess up their posture over time, because that facet angle wasn't exact on each side. Right. Just the same picture again. They're just kind of comparing the difference: cervical, thoracic, lumbar. So you can get a side view. You can look at the different bodies. So look at these over and over again. Okay. And there's your lumbar. There's your orientation. So here's your intervertebral disc. But here's that angle I was trying to show you guys. So just realize that really is only designed to go in this angle. Right? If it's rotated out, it'll cause the spine to kind of rotate a little bit. It can alter your biomechanics. All right. Talk a little bit about the sacrum. Somebody pulled it out. It's missing from the box. All right. But anyway, I'll show you on this guy, maybe. So superior articular process. This is gonna, there's a superior articular process right here. It's actually gonna articulate with alpha. Articulate means touch, or they come in contact with each other. Articulates inferior with the coccyx and lateral with the hip bone. So here's the coccyx inferior. Now here are those hip bones, all right? I don't like the term hip bones because a patient will always they'll put their hand back here and say, oh, my hip hurts. Well, no, that's your low back. Your hip joint is over here, all right? Just a small pet peeve of mine, right? The sacral promontory, right, is the antero-superior margin. So I think, well, wait a minute, I'm on the posterior. I got to turn this guy all the way around. Up in here. So when you're looking at these, kind of orientate yourself. And I know it's difficult. You guys aren't here to you know, kind of manual dexterity or actually palpate, or you know, some people are more of a hands-on learner. So I apologize. But at the moment, it's the best I can do. Right. Transverse ridges mark lines of fusion, and you'll see that. I said before, well, maybe if I tip, I'll probably end up dumping this thing. If I go in, oh, why is mute on? If I go in there, we gotta look at that. Right. You see these ridges in here, all right? Let me figure out. Right, that's where they fused. Remember, your sacrum was usually 5 bones, or coccyx is 6, or whatever. They actually fuse right after you're born or right before you're born. Right. So just look at those landmarks, and these will they'll pretty much tell you what they are: median, sacral, crest. So where's your sacrum? What's medial? You know, medial is the midline. Rough and bumps on the posterior midline of the lateral sacral crest. Roughened areas seen on the posterior side. Okay. So median sacral crest, you can see it right there. So these would have been, theoretically, they would have been the, see that? I apologize. These would have sort of been like the spinous processes of that area. Posterior sacral foramina. So remember, foramina is always a hole. Large opening for sacral spinal nerves. All right, so you can look at some of these openings, some of these sacral spinal nerves. So remember, just like with the skull, if there's a foramen, a medium fissure, or whatever, think of, well, why would there be a hollow spot in the bone? What would go through there? What would be the significance of it? What's the location? You know, so anything lower here is going to be for your reproductive organs, or things like that. Sacral hiatus, large opening at the end of the canal, down in here, and you're gonna just when we start getting into neurology, look at where the nerves are coming through. Coccyx is that tailbone, formed from 3 to 5 fused vertebrae, articulates superior with the sacrum. All right, very little function, but I said before, if you fall and you hit that, it goes anterior. What you literally, well, I've never done it, but you could go in to the rectum, go in and flip this thing back, all right? So I guess I would say I would never do that, but if somebody was in excruciating pain from that pushing on something, I guess, whatever. And there's just some pictures there. All right. Now, thoracic cage, I found this. So this would be the manubrium, body, xiphoid process. And they call this manubrium because it was supposed to look like a handle of a knife or a blade, sword. All right, so the thoracic vertebrae composed of the thoracic vertebrae posteriorly. All right, the sternum, the costal cartilages. Sternum and costal cartilages here. All right, so just realize the orientation. So we have 1, 2, 3, 4, 5. So they kind of attach directly to the ribs of the sternum here through these little parts. But if you're down here, realize these come here and they kind of angle up to attach here. And these ones down here are more of floating ribs. Let's see that. All right. Protect the vital organs of the thoracic cavity. So remember now, your lungs are going to be in here, your heart, your diaphragm's going to be in this area here. All right. Remember, your diaphragm is that dome-shaped muscle, so when it comes down, it opens this area. The volume is much bigger. The atmospheric pressure is lower, so air literally rushes in. When that diaphragm releases, it decreases the volume, increases the pressure, the air is forced back out. That's how you breathe. And when we get into that system, no, I don't think I'm teaching A&P next semester. Well, if you take pathotests with me, I'll go over that. All right, supports the shoulder girdle and upper arms. All right, to the scapula and the clavicle, just as like struts on your car. Right. Provides attachment sites for muscles of neck, back, chest, and shoulders. All up in here, sternocleidomastoid, serratus anterior. These names may not be familiar with you, but if you have any stress or tension, you may, when we start talking about these muscles and where they attach, you go, oh, that's why whatever's going on is going on. All right, so unfortunately, like I said, you guys don't have access to the skeletons, and I feel bad. But I literally have also taught this course about 6 or 7 times. And even in lab, I will leave all this stuff out, boxes of you know, like here we have boxes of bones and everything. And students will kind of look at it and they walk out and they'll just start looking at pictures and they, yeah, whatever. All right, so the sternum. All right, when you think of sternum, just start thinking of, is that your breastbone or whatever you want to call it. It was your breastbone, right? Now it's called your sternum. Also called the breastbone, consists of 3 fused bones. It's the manubrium, superior portion that articulates with the clavicular notches. Right. So the clavicle, clavicular notch right here is where they would attach. Manubrium, superior portion is here. And ribs 1 and 2, you can see here, 1 and 2. Right. Or some people have cervical ribs. C67, they're like prehistoric from, you know, whatever, however Darwinian, however far back you want to go. It's an anatomical normal variant, they call it. Okay, so the body is the mid portion that articulates with the costal cartilages of it's 2 through 7, 2, 3, 4, 5, 6, 7. All right, so in here, they're all attaching that manubrium, all right, body. And the xiphoid process is here, inferior end. It is a site of muscle attachment. All right, so some places tell you the diaphragm attaches here, because remember your heart has to attach to the diaphragm too, so it doesn't bounce all around your chest. All right, but your abs attach here and they can attach down there. All right, so if you've ever done certain abs that the next day you feel like right there, that's what's happening. All right, the jugular notch. Central indentation in the superior border maneuver. Right in there. There's a central notch. I can rest my finger right on that. Sternal angle, horizontal ridge across the front of the sternum. Right there. Right. The xiphosternal joint, point where the sternal body and the xiphoid process fuse. Right, and here it's not. Do we have it? Yeah, maybe. There's that notch. Jugular notch. Sternal angle. Actually, you can see those. If you guys remember what those were called. Talking about in the skull. Sutures, remember? All right, and there's the xiphosternal joint. Now there is a lateral, it's a lateral view, mid-sternal or mid-sagittal cut. The significance is here, all right? There's your kyphosis, all right? So just go anterior to that. Well, what organs are in there? So I was in here. So if I'm cutting this, what organs are in this area here, right? Well, your heart, your lungs. But look, your heart's way, way down here, your lungs. There's your diaphragm, right? Here, remember your heart is attached to that, so when it's beating, it's just bouncing all over like a tether ball. Xiphoid process projects posteriorly in some people. So sometimes this can poke this way, all right? And we just saw that's true, right? So there's that joint. If this is poking if this was turned and poking this way, all right? If you gave someone a chest blow, if you hit them, you hit them right here, that could jam into the heart. If you tear that pericardial structure, the pericardium around the heart, can cause major, major damage in the area. A blow to the chest, here it is. Chest trauma at the level of the xiphoid process can push the process into the underlying liver or heart, right? Can cause massive hemorrhaging, bleeding, right? And just kind of remember how hard it is to get into that cavity. Right? You've got the diaphragm there, huge muscle. You've got each lung, the pericardium and thoracic tissue all around there, sealing that all off. During CPR, hands must be positioned mid-sternum in here to avoid breaking off the xiphoid process down here and damaging underlying organs. All right. And the other thing you have to remember with that is you don't want to fracture someone's rib. You've got cartilage here, there's a little bit of flexion to it, because ribs, they can take, they can take months and months to heal, because you remember, if you fracture a rib, even if it's a hairline fracture, you never stop breathing. So that muscle is constantly, or that bone is constantly moving. It never is stabilized. Like an arm or a leg, you can wrap it, you can stabilize it to heal. You can't do that with a rib. So there's 12 pairs of ribs. They form the size of the thoracic cage, all attached posterior. It's easier on here. They all attach, the ribs are wrapping around here. They all attach posterior to bodies and transverse process with thoracic vertebrae. The true vertebral sternal ribs. Remember, vertebral sternal ribs. All right. They're all attached to the costal cartilages. The false or vertebral bronchial ribs are pairs 8 and 10. All right. And then I showed you the floating ribs. So we're saying pairs of 1 through 7, vertebral sternal. There's 1, 2, 3, 4, 5, 6, 7. All right. They're really attaching up here. See how that's coming up through here? All right. These are not. All right. These are vertebral bronchial. Right. Here 8 and 10. And then 11 and 12, literally they're saying, 11, 11 and 12. These are your floating ribs, no attachment to the sternum. You know, and then there's that rumor that, well, maybe next time you watch this video, Cher won't be alive anymore, but that she had her floating ribs removed, that her waist would be thinner. Even if it is, it doesn't matter. So they're just saying there 1, 2, 3, 5, 6, 7. Just realize how these are really kind of attached. These are not. They're kind of just attached to this. All right, and then just your floating ribs are down there. So I have seen a question or two of those before. So the ribs, there's a shaft bone. The shaft is a flat bone that makes up most of the rib. Right. And let's see if I can do that. It's really, really flat. Right? And there's a costal groove. I'm going to see if I can show you that. There's a groove right in here. Sorry, my screen's about this big for me to see. All right. But the costal groove, now, when you're doing this kind of thing, just think, well, why is there a groove there? What's wrong? So your intercostal nerves, blood supply is in there. Right. And then, you know, when we talk about the respiratory system, we'll be talking about bucket handle and how these can move, all right, for breathing. Because if they go anterior, we want to expand that space. Diaphragm is opening up, and we're increasing the airspace in the thoracic cavity to have the air rush in. And now as we contract it or bring the bucket handle down, we're going to make the area smaller, forcing the air out. Right. And then the other thing too here is if you have a lot of flexion, a lot of movement, the head of the rib here and that vertebral lateral part of the vertebral body, they can disarticulate, all right? And then when you breathe, as they move, it's very, very painful. Right? So we sound crazy, but generally, probably 70% of patients have ribs. I put them back in place and they're like, oh my God, I can breathe so much better, it doesn't hurt anymore. Right. So neck is the constricted portion behind the head, all right? And the tubercle, remember tubercle. Whenever you have a tubercle, think something's attaching to that, okay? Articulates posterior over the transverse costal facade of the same numbered thoracic vertebrae. And this is the area that I literally go in and, well, whatever, fix. So it's going in. Here, if I can, I'm going to give you put the big one and superimpose it. So it's literally going in here and it's articulating. It's probably going to be the worst video ever. All right. In there. See that? All right, but if you look, that head is over here. There's a neck. There's a tubercles right there. It's going in anterior, all right? Right there. So I literally, if I go to adjust this, I'm literally right there and adjust that. Sweet move. So when you're kind of looking at these, you don't have a lot to look at, but if it pops up on your lab exam or in the future or whatever, remember there's a head, there's always gonna be a neck. When we talk about the femur and things like that, there's gonna be a head and a neck and a greater tubercle. So these are gonna be all common, and just like I said before, the tubercle, something's attached to it. It isn't just there for, because they couldn't think of anything else to put there. All right, that's going to be it for today. I'm going to, like I said, I'm going to start ramping this up. The issue, you know, we kind of have at the moment is a lot of this stuff is just raw memorization. So I want to kind of get that out of the way. We'll start jumping into muscles, what the muscles are, and then kind of like the origin of insertion. And then we'll get into a little bit of the, well, a lot of the nervous system. All right, so we'll do bones, a little bit on joints, muscles, and neurology. So hopefully everyone has caught up, and the whole, right now, if you're watching this video in the future, right now it is the 11th or 12th or something right after our 2020 election. So a lot of people are just absolutely distracted by what's going on in the country right now. So everyone, if you have any questions, please email me through Blackboard, or for some reason, any email you send me that has more than one name on it. So if you're doing a group email with a class or whatever, it doesn't roll over to my Gmail account. So unless I go in and physically look at that specifically, I may miss it. So if you're going to email me and it's important and I haven't emailed you back or something's going on with Blackboard, email my personal email, which is c7t12l5s1@gmail.com, with just that in there, and I will get it. There's some kind of security breach. There was a security breach here at ECC, and there's a some of the steadfast things they're putting in place just to deter, I don't know what's going on, honestly, something, security. All right, everyone, I will make another one soon.